deliberate upon the problem statement. How big this problem of antimicrobial resistance is, and how much should we need to be afloat of this menace? A brief introduction to the entire topic.
So the topic, first onset, I would like to thank Dr. Saab for making an effort to talk about a topic which none of us register. हम कभी इस टॉपिक पे बात ही नहीं करते, जितने हमारे फिजिशियंस हैं हम खाली डायबिटीज और में जूझते रहते हैं, हार्ट डिजीजेस. But this is a very, very major catastrophe. The gap between the antibiotic resistance, the gap between a clinician and a microbiologist. It's massive and it is an unrecognized hindrance. हम अपनी लाइफ में क्या करते हैं, थोड़ा सा भी कुछ भी होता है तुरंत we start with an antibiotic without even thinking about the consequences. At least seminars like this, I'm glad that Newberg and Dr. Saab, they are all so conscious to make a change in treating and addressing this major concern. Now, what the problem which we all face as clinicians, that we might, like Dr. Saab said, that I might have done a very successful procedure, he's a neurosurgeon, so, but somehow something goes amiss and the patient might succumb. So, very first instance, what is important is to address the cause. So, I personally feel that you should judiciously and consciously decide about the antibiotic which you are planning to start with, and also think how long you are going to give, the right dose, right duration, and also plan about the de-escalation, when to stop, when to bring down, step down. So all this is very important, especially for all the doctors, all of us, because we do face this as a major problem in our day-to-day practice. Now with the era of Google and that public has also turned very much aware, which I feel is in a way good for us, so that we are also questionable and all at the same time answerable. For all this, we need a very good diagnostic backup, so that at every step the patient is managed well and rightfully. The patient care is on the right lines of treatment. I think this is good enough.
Thank you, ma'am. Now I'll ask the second question to Dr. Piyush Harisa. We keep hearing this term superbugs. When during our pharmacology studies, we used to hear something about beta-lactamase. Now, is this beta-lactamase the only thing to be feared about? What is this entire superbugs about? How dangerous it is for our practice, for immunity itself? And what about other things in this antimicrobial resistance that we need, the very basic things that we as clinicians need to know?
This is a topic which is most untouched actually, which Monica Madam has just stated up. And in my clinical experience as a clinical microbiologist and an infection control officer, I am facing the issue. It is not a per day, I would say it is for every hour and every minute which I am seeing throughout my practice. So first of all, to talk about what is superbug. Superbugs are those bacteria or microbials which are resistant to the routine antibiotics which we actually practice in our clinical day-to-day life. So those bacteria which are multi-drug resistant, those which are pan-drug resistant, and sometimes even if they are sensitive to some of the antimicrobials, they are in vivo resistant to the antimicrobials, and in vitro they may come up as a sensitive, one of the sensitive antimicrobial. So, keeping in mind, there are many things which we should understand and actually inculcate in the practice. So, I would like to tell you about what is actually happening in the environment, and there are three things actually. There is an agent, there is a host, and there is an environment to make a triad, which everyone have studied in our MBBS time. So the agent is that particular bug, the environment which we are giving them to proliferate, and the host is the one who we are treating for that particular bug. We are introducing antibiotics at the time of emergency presentation to our hospital, and that antibiotic is not at all rational. And because of this irrational usage of the antibiotics without having any antibiogram, without having any epidemiological data of what type of antimicrobials are sensitive to and in our geographical location, we are just introducing a new one because some of the MR has just told that this is one which has come up new and has passed clinical trials, but they don't have any efficient or clinical data to support the same. This is one of the biggest challenge. Second problem is, if a patient is taking antibiotics for a routine cough and cold and it is available over the counter. I think these things were we were discussing just before we started. So over the counter you can see if a patient having cold and just going to a pharmacist and taking up azithromycin 500 milligram and just taking it 1 or 2 doses because he's fine now, he need not to take another third dose. And that actually creates a big problem to the patient also and to the environment also. Coming up further, these bugs are actually coming up through our practice only. If we conclude the whole antibiotic therapy for that said particular disease or the state, there are chances that the bug is still sensitive to treat further. But when we stop in between and we don't take the antibiotic as per the norms, as per the rational usage, the genes are finally changing or shaping as they are required, and then the superbugs are coming up in the environment and we are facing the same problem. And if somebody must be, from your clinical practice must be knowing about that a patient, he has given the history that I have never been to any hospital, I have never been admitted for any chronic illness, but this is the first time a patient is having road traffic accident, coming to neurosurgery hospital, maybe directly to Dr. Shukla, and Dr. Shukla, when just sending that culture after patient is having some infections, maybe post-trauma or something, that is coming up with a pan-resistant data or something, maybe multi-drug resistant, and if something is coming up, maybe only with polymyxin B or melopenem, or maybe landing up to even polymyxin B is intermediately sensitive, may not be sensitive. So these data are actually coming up because the patient, when he was not going to any hospital, when he has not consulted any doctor any time in his previous life, he must have taken over-the-counter multiple types of antibiotics like azithromycin, norfloxacin, maybe oflox, maybe levoflox, maybe another third-generation cephalosporins, maybe over-the-counter drugs, anything could have taken. But we have no data of what patient has actually taken. If he had some body micturition in 10 years back, he might have taken nitrofurantoin maybe for 2 days and then stopped. So we don't know what has happened in the past. So these are the reasons for the superbugs, and I think we should conclude this question and then we can come up with the next one. Thank you.
Dear sir, you mentioned one term, pan-resistant cases or pan-resistant infections. We, all of us must have faced some reports in which a particular bacteria is resistant to all antibiotics. So what to do in such pan-resistant cases? Is there some guideline should we go for the best empirical therapy, or what should be our line of treatment? And for this question, I would also like, there are so many senior practitioners over here, so anybody can share his or her experience, whether in such pan-resistant cases, what practice are you following in pan-resistant cases?
Sir, for pan-resistant cases, first of all, हमको ये समझना होगा कि जो सैंपल हमें दिया गया, was that sample actually leading to the infection to the patient, or was that the colonization of that patient? Because if we are having saprophytic growth at our lab, it tends to be a pan-resistant bug, because saprophytic environment has different type of thing, and patient clinical thing is totally different from the saprophytic. Okay, so first of all, like for some, I'll give you an example also. In microbiology practice, the standard guideline states that you should always have a fresh urine sample for any UTI detection. But I could see that many of the clinicians are sending us that bulb of Foley's catheter. Foley's catheter tend to have colonization in the Foley's catheter bulb, and if it gives you a positive culture report, I bet you that must not be an infective cause for UTI. Reason being that it is a false positive result. So always send a fresh urine culture for for any UTI suspicious patient. This is number one reason of the pan-resistant which is coming up in the clinical scenario, because the clinician has not actually decided whether it was a colonization or it was a pathogen. Number two is, if patient is having a colonization from a longer time and it may lead to a secondary infection to the same patient, there might be possibility of pan-resistant. But for pan-resistance, I would say that there are a set of antibiotics which are available to be tested in vitro. We cannot test every antibiotic which is available worldwide, because we are also abide with certain set of guidelines by the CLSI, CDC guidelines, which we follow actually the American guidelines. So the guidelines says that you have to test, these are the antibiotics which you can test in vitro in your lab. If something coming beyond that, so you can give a certain antibiotic that clinician has to decide. Like if meropenem is coming resistant to any bug, and you have no other data that what other can be given in the scenario when meropenem is becoming resistant. So the guidelines says that if meropenem is coming resistant in vitro, the clinician should immediately start or switch the patient to ceftazidime avibactam combination, but the data is not available by disc diffusion method. So these are certain guidelines which we also reinstate to the clinicians, and clinician has to decide as per the clinical condition of the patient. So this is another thing. Lastly, I would again say that you first trace out what is the source of infection. If the patient is bedridden, if I take up a patient of neurosurgery, the patient is bedridden since last 10 days, he might be having some bed sore, and that can lead to the sepsis to the patient. So first of all, remove that transient flora. First of all, make the wound sterile, and then you start antibiotics. Then you introduce something new. Maybe the route can be changed, like we are following polymyxin B for the pan-resistant antibiotics. But to start any polymyxin or colistin, we can also give through inhalational route if patient is having VAP. Or if you have traced it out what is the actual reason where the patient infection source, where it has come from. So you have to think what is the source, and then you have to directly hit the source, and whatever route is applicable to that particular antibiotic, you can definitely go out.
Would you like to add up something as an infectious disease specialist?
So, at the very first onset when the patient comes to you, you have to judiciously decide that what antibiotic. First तो देखिए, सबसे बड़ी बात, पहले जब मरीज आता है आपको मरीज को देखना है, ना कि आपको ये सोचना है कि मैं कौन सा एंटीबायोटिक दूँ. What's up? ये this is something which I follow. Look at the symptoms. Look at the circumstances the patient has come to you. Look at the environment. Look at the epidemiological the setup. and then decide what antibiotic you should start. Instead of going in for like what normally we do, start with a very cocktail approach. This is something which I feel that is not the right method of starting an antibiotic. One. Two is this, like when Dr. Saab talked about PANNEL resistance antibiotics therapy. It is very tough. It is not easy. The gap of admission and sending the test and the report availability, almost 72 hours. In that time gap, anything can happen. You have to think about saving the patient. So these are the minuscule problem which you face. So it's very frankly speaking, Dr. It's like when we talk about PANNEL resistance organism, we do face it, and in that context, actually, we are misusing the antibiotics disproportionately, like the meropenem, polymyxin, all of them. So it is a problem which we all face. I feel that you should have, आप वेट करिए, आप देखिए क्या आता है उसमें, ऑर्गेनिज्म में क्या सेंसिटिविटी आती है, आप उसको स्टार्ट करिए. और जब मान लीजिए आपने कुछ स्टार्ट कर लिया है, आपके पास जब कल्चर रिपोर्ट आता है, उसको आप जो भी आपने स्टार्ट किया है उसको आप डी एस्केलेट करिए आफ्टर से 48-72 hours. That is a very a valid way of continuing the therapy with any antibiotic.
I totally support, madam, but there is again a clue in this. So, anytime patient is landing up in the emergency department of your hospital, definitely you start using the cocktail of type of antibiotics or whatever you decide. But my suggestion to you is, before you give any cocktail, one important thing is that you hit early, hit hard. That is fine. But before you introduce the first dose of antibiotic, at least take a culture sample, keep it aside, start antibiotics, send the sample maybe in a couple of hours, no issues with that. By the time you should connect with the microbiologist, what he has seen in the culture in the first night which has just passed on. So the microbiology lab must have some data or some information to you after the last night has passed, and he can at least guide you to at least what to go ahead, how to go ahead. Maybe the organism he has faced is budding yeast cells, candida. So you need to de-escalate the antibiotic, you to escalate with the antifungals, and this is how you can judiciously maintain your patient. Maybe you will be getting your culture sensitivity report in another 48 hours or maybe 24 hours. That is not the issue, but you have collected a sample at the correct time. At least you can plan to de-escalate the same antibiotics in another 24 hours. That will definitely add value to the patient.
What antibiotics or something to share? If you have something to contribute to this discussion on this particular question, how to manage pan-resistant cases in a better way, it would be very useful for the entire audience.
So,
anybody.
Before I take a question from the audience, I'll justify the last one which Dr. Shukla has just asked. So, again, I'll re-emphasize on that. So, if a patient report says that patient is clinically in sepsis and microbiology report says that it is a pan-resistant bug, okay? You need to check that whether the antibiotics which is going on, and there is no scope of further escalating the antibiotic. I am okay that the patient is already on ceftazidime, maybe Bactam combination, maybe patient is having some glythro added or some maybe a broad spectrum antibiotics added with that. But in my clinical practice, what I have seen that clinicians are not aware of that you should also start with anaerobic coverage. Clinicians are not aware of that he or she should also add antifungals to the patient with the patients which are not improving on broad spectrum antibiotics. So definitely open up our minds to first of all cover the gram-negative one, because polymyxin B or maybe ceftazidime, maybe Bactam or a meropenem, will not suffice in a patient having TLC count maybe 30,000, 40,000 and it is not clinically improving and further it is going up and up. So you should first of all think of that covering gram negative, covering properly the gram positives. Then after that you should also think of patient, if patient is in long-term beneficiary, you should think of anaerobic coverage, and lastly you should also cover the fungal part. Keeping in mind that fungal cultures are not readily available in 24, 48 or 72 hours. They may take up to 7 days because we usually do in our routine practice, fungal cultures are minimally kept for 14 days. So by the time you will get some fungal data, maybe patient has succumbed to. So let's not wait for that. You always have to hit early, hit hard, whatever you can do for the patient for clinical betterment, you do it. But parallelly, you should have an evidence-based approach and you should always send the samples to the lab, because if patient has, even you have lost the patient, at the end of some time you will have that evidence of what you have not missed. So that is more important.
So in some situations, today itself a culture report came from Newburgh lab itself. It was a sputum culture report. The bacteria that grew was Klebsiella pneumoniae. It showed a lot of resistant antibiotics and one sensitive antibiotic, that was polymyxin B. But the patient clinically improved. The TLC came down with the antibiotics that were on the resistant list. Meropenem and levofloxacin, 2 antibiotics were being administered. So the increasing TLC count has come down. The patient felt clinical improvement. The fever, the cough, the chest heaviness, everything came down. What to do in such cases in which the culture shows such antibiotics to be resistant, which are actually working in a clinical scenario?
Okay. So, sir, this is very close to my heart and I would really like to discuss this question because I'll tell you a story. I'm, I think, the only microbiologist in Varanasi who is giving reports like normal throat flora growth, normal vaginal flora growth, no pathogenic growth observed in 24 hours of the culture, no sterile cultures. This is how I reported very normally. No enteric pathogen grown stool samples. I think I am the only one because if I debate with my colleagues, they never give such type of report, or if they give, they are very less in number. So once I reported a sputum sample as a normal throat flora growth. The clinician came to me next day over the call. He was shouting like anything and he said, "Doctor साहब आपको पता भी है पेशेंट की क्लिनिकल स्थिति क्या है? नॉर्मल थ्रोट फ्लोरा लिखने के पहले आप सोचते हैं कुछ?" And he was a neurosurgeon unfortunately. So I said, "Sir, आपने मुझे स्प्यूटम भेजा, उसमें मिक्स्ड टाइप ऑफ ग्रोथ था और वो बिल्कुल भी क्लिनिकली नहीं बता सकते थे कि इसमें कौन सा वाला पैथोजन है। दिस इज द रीजन, क्योंकि हम स्प्यूटम जब देते हैं तो बहुत सारे मिक्स्ड ग्रोथ उसमें आने की टेंडेंसी होती है। तो दिस इज द रीजन आई सेड दैट नॉर्मल थ्रोट फ्लोरा ग्रोथ, इफ यू आर सस्पेक्टिंग एनीथिंग यू जस्ट राइट इट डाउन कि द पेशेंट इज हैविंग क्लिनिकल सो एंड सो थिंग्स एंड देन आई कैन डेफिनेटली कंसीडर दैट क्लिनिकल डेटा फॉर माय रिपोर्टिंग पर्पस." देन ही सेड, "आपको किसने कहा स्प्यूटम है?" इट वाज एन एंडोट्रेकियल एस्पिरेट। मैंने कहा, "सर, the clinical report which I have got has wrote sputum and it is your hospital's letterhead which is written. I can share you that photograph." Then he was a little bit normal after that. So, sir, the biggest problem is that once I have reported sputum to you, I never ever get any clinical information from any clinician regarding the status of patient, whether patient was clinically having maybe LRTI, maybe something else, or whatever you are suspecting. So I at least need some provisional diagnosis from your end also, so that I can decide whether I have to report it or may not have to report. First of all, even if I am going to send my sputum sample, or any one of us are going to send any sputum sample to a lab, something will grow, definitely grow, because it is not a sterile environment. So Klebsiella might have grown and it must be a single type of colony which have grown on the plate. I am at the laboratory side, you are at the bedside. You are the clinician, I am at the laboratory. So this is the bridging gap between me and you, that I am not able to decide whether this report has to be released as Klebsiella pneumoniae grown and the sensitivity report has to be attached along with that, or it has to be reported as a normal throat flora. So you have to always write something for me also to decide whether it has to be reported or not to be reported. Please make a note to if you are actually expecting a good microbiology report. So this is my suggestion and a request to all the clinicians.
So the take-home message for us, the clinicians, is that our acquisitions should be well informed, and we must keep this communication alive between those who are practicing the lab medicine and the bedside medicine. Anybody from the
So मैं एक चीज़ और इसमें ऐड करना चाहूँगा. हमारे पास UTI के लिए सस्पेक्टेड यूरिन कल्चर्स आते हैं. I am at Newark Diagnostics doing all type of cultures and we are doing good number of cultures. अभी क्या है कि जब यूरिन कल्चर का सैंपल आता है तो देर आर एट टाइम्स when gynecologists are sending sample just to rule out UTI while the patient is having antenatal time, right? So all antenatal patients tend to have a urine culture or urine routine just for the sake of that UTI is ruled out. But I am seeing those samples at my lab. Some female may have the clinically UTI. Some female may not be having UTI or they are just normal. So the plate says, let's say enterococcus आता है, it is very common. मैं पहले क्लिनिकल डेटा देखता हूँ विच इज नॉट अवेलेबल, तो पहली चीज ऑब्सोलीट हो गई. दूसरी चीज फिर मैं देखता हूँ इज शी इन अ रिप्रोडक्टिव एज ग्रुप. फिर मैं देखता हूँ यस शी इज अ फीमेल इन अ रिप्रोडक्टिव एज ग्रुप. फिर मैं अपने आप से ये सोचता हूँ इज शी माइट बी प्रेग्नेंट. फिर मैं उस एंटेरोकोकस को दूं या ना दूं, दिस इज माय क्लिनिकल जजमेंट अगेन. Then sometimes I may be able to connect that clinician or may not be able to connect the clinician. तो मैं फिर अपने माइक्रोबायोलॉजी एक्यूमेंट से ये सोचता हूँ कि कॉलोनी काउंट देख के डिसाइड करूँ कि क्या ये उसके पेरिनियल एरिया का फ्लोरा है या एक्चुअली में यूटीआई कॉजिंग एजेंट है. Sometimes I do give that report as a positive report. Sometimes I decide that it is not a actually pathogen which is causing UTI. So there is a very dicey situation, and today I think we are able to clear up some of the our questions, and we'll fill the bridging gap between the bedside clinicians, that is you, and maybe our laboratory side.
It's also very important that how the sample has been collected. Very important. Any microbiological sample has to be collected by the books and norms. We don't follow it. I think like we were taught how to take blood culture. I am surprised that people don't know how to take a blood culture. But it is like the protocol should be followed. Then also you will get the right result.
Ma'am, can you shed some light on this very important topic? How to collect samples, particularly in patients who have some medical device going in the body? Means how to collect sample in a catheterized patient, urine sample, how to collect sputum sample or endotracheal aspirate sample in an intubated patient in the proper way, and what all the blood culture. Particularly these three samples are the most commonly sent samples.
Collecting the samples is one of the most important thing before you send any sample to the lab. For urine samples, we always have something to tell the females, more of the females actually, because the samples which we are getting from the female patients are most of the time contaminated through their perineal region, and we are not getting the actual pathogen. So to rule out that thing, we always has to ask the female to please sit in a squatting position, please wash your perineal area with soap and water, then you separate your labial folds, and then you take a midstream urine. So this is the ideal protocol a female has to follow, and for males, we always tell them to check out the genital area, which should be clean. You wash it, you retract the glands of the penile area, and then you take a midstream urine. So this is how we have to actually tell them before sending any culture sample. If you really want a true positive patient culture report, because most of the time we are getting false positive, and this is one reason that we are getting multi-drug resistant, pan-drug resistant, because they are all the colonizers.
this differentiation between colonization and infection is absolutely necessary. What about catheterized patients?
For catheterized patient, we always suggest them to clamp the catheter first of all, wait for maybe half an hour, and then from the another port you directly take the sample in the urine container. Never ever take a sample from urinary bag first of all, and never ever think of sending the Foley's bulb to any laboratory sample for urine cultures for suspected any UTI patient. So that has to be taken care for all the UTI patients.
Does it hold true for endotracheal tip cultures also?
Yes. So for the endotracheal tip, we never ever ask anyone to send the tip to us. Always send a endotracheal aspirate, which gives you a better and clearer picture always. So first of all, patient has to be as suction. First of all, you do the suction, wash with normal saline, and then you take the aspirate and send the sample to us. So you will get the actual back picture after that. And for blood cultures, I always send 2 samples of blood culture for any patient. If a patient is, blood cultures never ever taken for OPD basis, because patient is okay to, he's just coming up to your OPD, walking down, and he's fit and fine. So most of the time blood cultures are sent in IPD, or if patient is having a long-term febrile illness, then we sometimes suggest blood culture. So always the ideal method of blood culture is you first take up the bottle, you clean the whatever area you need to take up the blood culture, maybe any vein you are pricking going through it. Then you take a spirit swab, burn it over the blood culture bottle to make it sterile. That area has to be sterile. Then you directly inject the syringe, take up the culture and directly inject inside the bottle. So you have every step has to be aseptic, and before you take that blood culture, the asepsis has to be maintained in the room as well. Because anywhere if you are sending blood culture, any contamination, air contamination can also happen. Because it is a very sensitive testing, and blood culture if coming positive, patient can false positive, again leading to misdiagnosis, and true positive can be misdiagnosed again. So both of the things can be dicey situations for the clinicians to judge.
Thank you, sir. Before we take up the next question, would anybody from the respected invitees like to add something on this issue of some culture report showing a particular antibiotic to be sensitive, but the patient clinically is responding to some other antibiotics, that antibiotic coming as negative? So we land ourselves up in a very tricky situation, whether to go with the culture-based antibiotics or whether we should go with our clinical acumen, and how to deal with this, because we have, I think, decades of experience with us, with so many senior physicians and surgeons who must have dealt with thousands of patients. Anything, any input from your side? So if we don't have any inputs, sir, you talked about some guidelines, the CLSI guidelines or CDC guidelines.
Something known as 70-30 rule. 70-30 rule is that there are chances that 70% tendency of coming in vitro resistant, but there are 30% chances again that the antibiotic is in vivo sensitive. And the same goes for that 30% chances that if the patient is having that particular antibiotic sensitive as per the reports, and 70% there is likely to be resistant in vivo. So it is vice versa, and that can happen in clinical situations. And this is the reason that sometimes if we have sent a culture report and we have got the sensitivity testing, and it shows that cefixime is resistant, and we have just given the patient cefixime from last 3 days and patients clinically have improved, and there is no harm in continuing cefixime if clinically patient is okay, TLC is going down, sepsis markers are okay. So you never know that if it is actually going to be in vitro sensitive or resistant, but there is a 70% chances it may come up.
So you mentioned about CLSI guidelines. In brief, can you have that important salient points that we as clinicians need to know about these guidelines?
So CLSI guidelines are actually given by the CDC Atlanta, is a USA-based guideline, and CLSI full name is Central Laboratory Standards Institute, which is based at Atlanta, USA. So they publish a guideline every year in the month of January. So अभी इस साल का हमारा January वाला edition is about to come, and they actually make a data pan world from every country. They collect the data, whosoever is following the USA guidelines, and then they conclude a session amongst themselves. They have a CME and conferences, and then they finally publish that data that these are the set of antibiotics has to be tested. These are the sets of antibiotics which has to be added up to the current guidelines, and these has to be obsolete now. So we have two types of guidelines which are available worldwide. That is, one is European guidelines, that is UCAST guideline, and another one is USA guideline. We Indians usually follow the CDC ones, the CLSI guidelines. So CLSI tells us that these are the antibiotics which are routinely used for clinical practice. Like, I'm quoting an example against that. If we have to use penicillin, so ampicillin or penicillin or whatsoever antibiotics can be tested, their certainty is against like the bugs. I mean, the patient has culture positive and staphylococcus has grown. So staphylococcus is a gram-positive organism, gram-positive cocci. It is sensitive to so and so antibiotics. But what are the sets of antibiotics which we have to test? That CLSI actually decides. So CLSI tells us that these are the group of antimicrobials. These are the antimicrobials you can test it by disk diffusion method. These are the sets which you can test by MIC method. Acha, the biggest problem is that the labs which doesn't have any microbiologists, what they do is they take up the data from internet, they publish every antimicrobial by disk diffusion method, and they give you a set of report. I mean 40-45 antibiotics. You will see 2-3 pages report of their culture sensitivity report. I just gone through one report in the evening, and while traveling I was discussing with Mani ma'am. That antimicrobial, given the list of antimicrobial given that urine culture sensitivity report, E. coli was grown. E. coli is an enterobacteriaceae. For enterobacteriaceae, they were giving streptomycin, tobramycin, the first generation cephalosporins which are already obsolete, which nobody is using, penicillin, ceftazidime. So always think that the lab which is reporting is actually, are we going to use it in clinical practice or not? So the sets which we are not using are already ruled by some guidelines, and those guidelines has to be followed, because a neurosurgeon even doing a surgery is going through books, because if book has not stated that kind of procedure or how many layers he has to go through and what type of incision he has to put on, he is not going to practice correct actually. So this is how microbiology and the laboratory is also guided by some guidelines.
So I got a few samples in which all the bacteria that grew, they were sensitive to getafloxacin. Now I started searching for getafloxacin, and I searched the entire city, but getafloxacin was not found. The getafloxacin is only found in the form of ear drops and eye drops, but all samples are sensitive to getafloxacin. So what is the solution to this problem? Why is disconnect between lab medicine and bedside medicine? And can we make a tailored approach, individualized approach? Can some Indian guidelines come through? Is there some work going on in this direction?
Sir, actually, people are not judiciously practicing even. The issue is that most of the labs are not judiciously practicing. They are based on the technicians, or maybe pathologist is doing. If I do not know about histopathology, how can I report histopathology? So the same way, if pathologist doesn't know what is culture and sensitivity, how a pathologist can report culture and sensitivity? This is how I actually inculcate. And sometimes I will not quote any name, but yes, I could see that many of the labs are doing such unethical practice. Technicians are reporting, they are making their own guidelines, they have their own set of thought process and the fixed thought process that we will give you so and so. Achha. Another problem is, the other darkest side of this thing is, the clinician also wants to see 2-3 pages report. So they add up more and more and more number of antibiotics irrespective of whatever they want to. They have no idea whether this antibiotic is there any guidelines which tells you that is it sensitive, resistant or not resistant, or to be tested, not to be tested. There are companies, if they are making any kind of antibiotics, so there are companies which are making any kind of antibiotic tests for testing. So anything to be tested, anything to be given, if this practice clinician would like, then there is no replacement for that. But if you are really willing to get a true culture reports, you should always talk to a microbiologist, whosoever is practicing in that particular lab.
Thank you, sir. We also get reports in which the sensitivity is type of quantified in the form of plus, double plus, triple plus, 4 plus, or highly sensitive, moderately sensitive, intermediately sensitive, or we get some values against MIC, 0.4, 6, 1, 2. What is the importance of this? Does this number hold some importance? If so, should we go for those antibiotics which are triple plus sensitive, or for those antibiotics which have a lower MIC value? What does the guidelines say about this?
Sir, before I speak on this, I think my background should be very clear so that people will also understand the importance of institutes. So I am an alumni of IMS PHU. Then I did fellowship in specialized anaerobic techniques at AIIMS New Delhi. After that, I was at Maulana Azad Medical College in Rohtak Hospital, Delhi. After moving from Delhi, I was with Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. And finally, I reached to landed to Varanasi. Maybe by the blessings of Baba Vishwanath, I don't know how I have just landed up in here. So, in my practice from these institutes, I have never been through any book, any journal, any research paper that there is something known as 1 plus, 2 plus, 3 plus and 4 plus. Definitely there is something known as resistant, sensitive, and earlier it was moderately sensitive. Now the terminology has changed to intermediate. Another term, which is a new term you might not have gone through any report, is SDD, that is susceptibility dose dependent. It is for few antibiotics like cefixime, 4th generation cephalosporins. We give SDD, that means if you adjust the dose, patient might have in vivo sensitivity. So, first of all, we should always understand this 1 to 4 plus is nothing. Either it can be resistant, can be sensitive, or can be intermediate. Intermediate means you need to adjust the dose, or you can add up something to make a new antibiotic. Like we have already introduced many antibiotics in these times. I mean, they are just mixing and matching with multiple BLK-like combinations and penicillinase and those things. I think this was one question number one.
What about MIC values?
Yes.
The importance of MIC values.
See, sir, MIC is always going to add some clinical value to your reports. But issue is, my practical challenge, I would say, that people tells us that patient has a very low pain capacity. So MIC, I think everybody of you is a good clinician and you must be knowing what is MIC, that is minimum inhibitory concentration. It is a sensitive parameter to decide whether the antibiotic can be given and whether it is going to add some value to the clinical data of the patient or not. So MIC and MBC are two things. MBC is minimum bacterial concentration and bactericidal concentration, and this is inhibitory concentration. So these are the basically liquid concentration methods which tells us a better data than the disc diffusion method. But the only problem behind it that the pain capacity of the patient. So you always has to tell the patient and counsel the patient to at least pay something extra to get a better result, to better overview, and those MICs which are quite high and getting sensitive to your report. If you are giving that particular antibiotic to the patient, either you have to give on a higher doses or patient may not respond to the antibiotic, which we were just talking about, that in vitro sensitive tha, but in vivo resistant hai. This is because the MIC was quite high, or you have not adjusted the dose actually. So MIC really adds up some value, but patient pain capacity is a big question.
Sir, in the footnotes of many reports, we find that some bacteria are innately resistant to some antibiotics and vice versa. Can you shed some light on such things that we don't fall in the pitfalls?
Yes. So in the footnotes also, and I think it is a microbiology acumen actually, some of the bacteria there is known as intrinsic resistance. So the genes of the bacteria tend to be that resistant with few of the antimicrobials. I'll quote a very common example. You must have gone through this report. If you are, have you any one of in the clinicians can tell me how many of you have seen Proteus mirabilis or Proteus report in your clinical practice? Any one of you? Proteus mirabilis or Proteus vulgaris, patient having Proteus infection. So you treat that patient with nitrofurantoin, your whole life will go in vain and patient will not improve. Because nitrofurantoin is intrinsically resistant to Proteus and not going to add up any value to the patient. So even if any lab, which is again coming back to irrational use of or the practice, so if any lab is giving nitrofurantoin sensitive in Proteus, you should directly ask the lab who has reported this, because it is intrinsically resistant. So we never give nitrofurantoin sensitive, and likewise there are many things. I mean, for staphylococcus, people are giving other than the gram positive, for gram negative, I would say rather. E. coli, you can see few reports says vancomycin is sensitive. So vancomycin and linezolid for a gram negative organism is never going to work for that. So this is how we should always, as a clinician, should also know what has to be given, what not to be given, and the report should be very clear and rational.
To ma'am, I would like to ask a practical question that I have been facing in my practice. Often we operate cases of port spine or tubercular abscesses where the pus is actually organized. For that sample, what tests do we need to do? We can't go for culture sensitivity probably, or can we go, or should we go for biopsy? Means clinically it is a tubercular abscess, but since the patient has taken some ATP for certain duration time, often the pus becomes very organized. It comes out as soft tissues. What tests to be done? Means if we need to get some information out of that sample, should we go for culture sensitivity, should we go for biopsy, or what should we do?
In such cases, we usually advise for the molecular test like PCR with the expert, because in that case, if the bacterial DNA is present in the sample, then we are able to isolate it and we are able to report it.
Port spine cases, if you are not getting the frank pus and you have treated that patient, see, the biopsy or histopathology will definitely give you an idea about what type of granuloma it was there. But simultaneously, you should send the sample, the same tissue sample, because it's a precious one. You have just pricked the patient. So it is better to send for gene expert or PCR for the same sample at the same time. You'll get the load also along with the sample. If it is positive, you'll get the load. If it is negative, then you can just rule out that the patient is responding to it, and then you can just continue with the treatment or maybe stop.
Thank you. So for the next point, I would again like our respected invitees to come up with their own inputs. A lot of newer antibiotics are often cross our paths. Most of the times it's the medical representatives that come with a lot of newer antibiotics with exorbitant prices, and they come up with one or two studies that show almost 100% sensitivity and things like that. I have just written a few names: levonadifloxacin, then there is something called cefepime plus enmetazobactam, dalbavancin, and sort of things like that. Or even the use of EDTA. EDTA is being combined in many antibiotics in order to increase its sensitivity. They are claiming that the addition of EDTA adds value to that antibiotic, and it is working against not only the beta-lactamases but a lot of other antimicrobial resistant causing enzymes. So as an infectious disease specialist, ma'am, what is your input? And I would like all our respected delegates to share their experiences with these novel antibiotics. Should they be kept as reserve antibiotics? Should they be used upfront? What should be our best way forward?
First concept, never be guided by a medical officer. You are not just, he is doing business, you are doing his business. You are not doing your business. So, never be guided by these kind of modalities. Go by your own clinical acumen. Go by what your jurisdiction, what is there in your jurisdiction. Personally, if you ask me, I have used this levofloxacin. It's exorbitantly expensive. I think twice before I mention, and I would never say that the results have been very good with those type of antibiotics. Second, I have not used this EDTA to increase the sensitivity. I've not used any of these modalities which are not being recommended. They are being put as guidelines, but actually not being recommended in any of our clinical textbooks. Third is this, that there is the pattern of antibiotics which you will want to use is something which your own, the history, the area from where the patient has come, the entire clinical scenario will individualize, will let you decide what antibiotic you have to use. So go by that. Go by the first-hand information of sending a culture of sensitivity or the first test which you can send. Never be guided by anything which is like out of the books. This is what I have. In front of me, he can give you not one but lots and lots of inputs. Sir, please.
I need to give my opinion on this. I'm hardly a specialist. Definitely, I go by the books and I follow the latest recommendation of All India Institute Antibiotic recommendations, the application that I have downloaded, and I follow strictly that and refer to my textbooks. Rather than using the latest and highest antibiotics and all those things, I look up to other specialists which are there to guide me from time to time. So I just go by books and try to keep it simple. As my textbooks recommend or my application or Institute Antibiotics, the latest version, I will also recommend everybody to download it on the books. It's a very good ready recommend. Thank you.
No discussion on microbes or antimicrobials in India can be complete without mention of tuberculosis. So we had this menace of MDR, then came SDR, and now there has come TDR, total drug resistant disease. As a clinician, what should be our best foot forward if we are clinically suspecting a tuberculosis? Because many a times the samples do not have a very good diagnostic yield, particularly in TBM or neurosurgical TB cases. The CSF yield is probably, the positive yield is more or less 10% only. Should we start ATT upfront? Should we go for better tests in order to decrease this trend of newer resistance? What should be our steps?
So by the time, we are now, I am getting a lot of, I don't get any more simple tuberculosis. I do get a lot of MDR, SDR and TDR. So you have to be very upfront about it. But there is one problem which I am facing as a clinician, is that you don't get those drugs. For that, you have to get notification, you have to, like in my case, I have to send the patient to the TB center in Niju. I will not get drugs. They are not giving us drugs. Basic drugs, first line drugs you are getting, second line you are getting. After that, you are not getting. You have to...
availability of second line ATT is, I think, not even permissible in private practice. The government acquires those drugs separately. So, even on the slightest clinical suspicion, should we start the ATT?
Yes, definitely. No, there has to be test proven. It is not anymore like that. Like prior to COVID, when we started our practice, I started my practice. My seniors would be like duration of fever and history. TB jarur hoga. It's not like that anymore.
All of us in our respected Delegates, you must also have faced tuberculosis of various body parts. We have pulmonologists among us, we have pediatricians, we have general physicians, we have general surgeons. So what do you do in your clinical practice regarding this menace of TB? Because the government is claiming that, the government used to claim that they will eliminate TB by 2025. So they even changed the name of the anti-tuberculosis program to from RNTCP to NTEP. But all of a sudden that 2026 has come and every fifth sample is at least clinically suspicious of TB. So what guidelines or what practice do you follow? Any input from the audience or from the delegates? Any input? It will be very useful for the rest of us. We have senior physicians among us, we have senior surgeons among us. We must have faced cases of abdominal tuberculosis, pulmonary tuberculosis. Anything that you want to share? Sir, do you want to have some input on this particular topic?
I think just as Dr. Monica has rightly said, the common medicines, the 4-drug or 5-drug regime that we used to start, once we are sure that we are dealing with a case of tuberculosis. Sometimes we are not very sure also, and there is a dilemma. So I go to the old thought of giving a therapeutic trial for about 4 to 6 weeks or so. So that's also a very good practice. It's one of the diagnostic tests also. But after that, if the patient is not responded and he's clear-cut tuberculosis patient and he's XDR or MDR, definitely he has to be referred to a higher center, because the government has a very keen note on this issue, and we should be helping the government in eradicating tuberculosis. So we should be handling those cases which we can, which have responded, but if they have not responded, they should be referred to a higher center. Unfortunately, I have gone through such XDR and such cases where we sent the patient to GB Panth Hospital, Delhi also, TB center, and to Bombay also. But that patient XDR died after 3 or 4 hours, years of intensive and best treatment available in India. So I have burned my hands with XDR in those cases. So I would definitely say early diagnosis, proper treatment, and full doses, because anti-tubercular drugs have to be calculated on the per kg body weight also, and they have to be given in one, all the medicines have to be given in together, not in divided doses in around 24 hours. So those things have to be followed, and we should be helping the government eradicating tuberculosis. I think it's very far-fetched to eradicate by 2025, but we have to do our best to help the government do that.
Sir? As a lab physician, Dr. Piyush Hari sir expressed or communicated his expectations from us clinicians. Do we clinicians have some expectations from the lab physicians? Yes. A take-home message from his statement was that we should fill up our requisition form in a proper way. We should be more informative in our requisition form. We should be more communicative with the microbiologist or the pathologist. I, in my clinical practice, often try to talk with the radiologist. A lot of radiologists have come up here who have very good relationship with me. So every case I try to discuss. So this is the expectation from a lab physician. We as a clinicians, this is a proper platform where we have a very eminent microbiologist who is very passionate about his work. So if in our clinical practice we feel that there is some gap, there is some lacuna, there is some misconception, some lack of communication between us and a lab physician, I think we can utilize this evening in expressing our statements or our concerns with him as far as a lab physician is required. If anybody has some input, it will be very useful for the rest of us. Because we don't get our microbiologist to sit with us every day. We are all busy with our daily practice. And so I would like to utilize this opportunity, and I would like to invite everybody, if you have some input, something to talk with the microbiologist, because after that we'll have the last concluding question from my side that I have prepared for this evening. So if anybody of you have something, sir has.
A very important thing, because we are all getting cultures and sensitivity tests done, and most of the time for urine, for maybe pus, for sputum, for so many other things. But I think we physicians and clinicians always are looking at it very skeptically, whether this report is good or correct, why should it be followed or not. And ultimately we are following our conventional things. Because very few bacteriologists are there in practice and at hand. So definitely I would like our microbiologists to give us physicians a tip or an insight to how these cultures, test reports and all these things are coming to us and how much reliable they are. We should be relying on those reports or not.
Thank you, sir. Sir, first of all, we should also understand that the era has changed now. We as a lab physicians are also abiding to give the reports which are clinically relevant. Because your practice and our lab testing both includes to make one goal, that is an evidence-based approach. So everyone has to be on their toes to make the evidence successful. And it is not only the responsibility of a lab physician to report all the evidences, the lab should also get vice versa, the same kind of interrogation from your side, the same kind of clinical data from your side, and it should be always a two-way communication between the lab and the clinician. At times we talk to the radiologist because there are some discrepancy with the CT scan reporting, there may be some clinical changes and there are the radiologist who is reporting something else. So we do find sometimes. But I barely get a call from a clinician asking whether your report was, this is what we have got in the report and can you guide me how to go ahead with the sensitivity testing. So we also expect that clinicians are busy and definitely the clinical practice is too huge because everybody is busy with multiple things and multiple centers also and they have a good number of patients. So we should always talk to each other to close the gap, and this is the biggest challenge for today's evening also to accomplish the bridging gap. And but my suggestion is that please open up, discuss with the lab physicians, whosoever is behind the report, or a pathologist or a microbiologist or any other expert. You should always talk to them. This is the thing I would say.
Definitely, this is very important. Just one comment. This is definitely very important thing which I used to practice, but definitely the times and things have changed. I used to talk to my radiologists and pathologists. They are the backbone of any physician, any clinical practice. So definitely, as he says, slowly and slowly our requisition for pathology and radiology is limited to just writing one simple sentence, and this is it, without giving any background or without knowing, letting the bacteriologist or pathologist know what you want to know. So exactly, I think our requisition on the form should be a little bit of clinical background or some clinical information so that it is helpful for the person behind the screens to be more helpful to us, definitely.
And I would also like to add on the last discussion we had about the newer antibiotics. I actually missed that thing to just emphasize. Like newer antibiotics which are coming up, the few of the MRs I could also see in my hospital that they are coming up with some antibiotics along with EDTA or like that. My simple question to the audience is, EDTA is what? It is a chelating agent. Can a chelating agent combined with antibiotic, how is that agent going to improve the sensitivity of an antibiotic? It is not. There is no FDA proven data available worldwide. It is not Indian data. No data is available worldwide that EDTA should be clinically used. We are using EDTA in our purple color vials for the taking samples of CBC, right? So EDTA cannot be a better sensitivity improving agent for any time, first of all. And secondly, as sir has rightly said, always go by the books, you can go through the researches, go by the journals, and the data, actually proven data which is available worldwide. Never go through the MRs, they are just selling out anything and everything, whatever. It is up to you what you have to use, what you need not to use.
For a concluding question, all pervasive question, now that the menace is here, what is the way forward? And for this I would like all the panelists to chip in if they have some idea, and all the respected delegates.
Sir, excuse me, just I have one question, Dr. Piyush sir. I am a Dr. MS, I am a chest physician. My question is that just I am giving a scenario of a patient. One patient is admitted in a hospital. It's going on, we have given ceftriaxone antibiotic. Then after 2 days, suddenly patient is deteriorating, like requirement of oxygen, NORAD requirement. We have shifted on a meropenem and we send a culture. But after we are expecting a culture on meropenem 2 days, after that we are waiting for the culture report. But in culture report, there is a list of the antibiotic. There is no antibiotic of poly, cholesterol or ceftazidime. Then how we can proceed? There is only list of that antibiotic amoxicillin, ceftriaxone, piperacillin, tazobactam. All are resistant. Then how can?
Sir, what was the bug reported?
Klebsiella.
Klebsiella.
Yes.
Sir, first of all, I would recommend you that if patient is admitted in your hospital and already on antibiotic, please try to send a culture before you initiate the first dose of ceftriaxone. Even if you are using ceftriaxone, it is just a third generation cephalosporin, but I would suggest you not to use it without evidence. Number one. If patient is clinically deteriorating after ceftriaxone,
After 2 days.
After 2 days of ceftriaxone, and
Yes.
third day you have sent a culture.
Yes.
So culture report positive, that means patient was not on the correct drug, first of all. So you have to escalate. Now, the patient is again on meropenem, but the report was not suggestive of meropenem. It doesn't have meropenem.
No.
But for Klebsiella, meropenem, polymyxin B, colistin, all can be tested. Unfortunately, the lab might not have that sense of testing those drugs, or the microbiologist may not be present there in that particular lab for the testing and sensitivity purpose. So the technician or whatsoever, other than the microbiologist person whosoever is reporting, doesn't have that acumen of reporting those things. But these should be reported, and your report should have those things, whatever the report you have in your hand. So this can be escalated, but if what happened after the patient was on meropenem, the patient improved?
Yes. No.
And after that, what patient improved or not?
Yes.
But if you had no data of polymyxin B and you have just switched to polymyxin, maybe if you could have continued with the meropenem, patient might have been improved.
No,
Yes.
the thing is that after 2 days we have shifted on meropenem. Again we are waiting for 2 days for culture report. But in that...
Sir, I'll also clear one dilemma over here.
Yes.
That as per the guidelines which we are getting, so all the urine cultures, if sterile, to be reported in 24 hours. I could see many labs who are just keeping it for 72 hours and reporting it as sterile. So it doesn't add any value to the clinician actually. They're just clueless for next 3 days if whatever report is coming, not coming. I, as a microbiologist at Newburgh Diagnostic, madam is very well knowing of that. We are getting blood cultures. The moment blood culture machine pings it a positive or flags it as a positive culture, we make a gram stain. At the same time, whatever we see, we prompt it to the clinician. Sir, it is a gram negative bacilli which has grown. It will be grown tomorrow and then AST will be put in another next 24 hours. So it will take another 48 hours to finally prove you that whatever the sensitivity will be. But if you have started the patient on gram positive treatment, you should immediately switch the patient to gram negative. Or you may start with a broad spectrum therapy for gram negative. Or if there is a budding cell, then you can immediately add some value as adding up for antifungals. So these basic data you can get from the lab. And another suggestion to all the clinicians is, please go back to the basics. Before you get a MIC report, get a gram stain report, ask for a ZN stain report. Gram stain will give you the data of the patient, what kind of infection patient is having. Because if you have a patient which is not improving on any antibiotics and patient is in case of LRTI, you just send a sputum sample to us or maybe a bowel sample to us and we'll just tell you what kind of things were there. Maybe patient is having a candidiasis and you, suddenly अगर आप जैसे ही आप antifungal add करेंगे, next day will feel the change. है ना? तो gram stain will also tell you whether it is a invasive candidiasis, non-invasive. वो भी pseudo hyphae के basis पे we can rule it out, right? So you should always go by the basics and you start ruling out the basic things first and then you can go to MIC and whatever extent treatment you can go through.
I thought that that pretty much answered the question. It was a good question also. The last question from my side: what are the recommendations for culture samples that we send from OT, from cath lab, from hospitals? How frequently should be they sent? From what all surfaces or should they be sent?
Sir, for cultures, these are the cultures actually known as environmental sampling. So for a hospital setup or maybe small clinical setup, the critical areas, I mean the ICUs, OT, CCU, HTU and emergency department, these are the critical areas. So for the critical area, you should always do a sampling at least weekly. But I would say weekly if not possible, then at least fortnightly you should go ahead. For non-semi-critical areas, I mean the areas where the wards and you should go ahead. Because see, sir, infection control, keeping a breast infection control, you should always have an infection control officer to monitor your hospital. Any physician can be an infection control officer as well. It is not only a microbiologist. So any trained person who can monitor that, you should go ahead with that. Number 2, for OTs, you should always send air cultures and surface cultures. So OT air cultures has to be done every 15 days minimum 15 days. So for that, you should keep a open plate, blood agar, you just ask the microbiology lab to send a blood culture plate. Blood culture plate has to be kept open 2 feet from the lower surface, 2 feet from the corner, in any corner of the OT, and just keep it for 30 minutes, close the door and close the plate, seal it and send it to the lab. Lab will give you what is the CFU per metric cube of your reporting, I mean the air infection control monitoring of your air part of the OT, what is the air exchange entry and whether your HEPA and laminar are working well or not. And accordingly, you can further take up the action. Like for nowadays, fogging is not at all recommended. It is the, other thing, deep cleaning and quaternary ammonium compounds. These are
high risk areas are furnished with.
Yes, most of the areas are, but to ascertain whether the HEPA filters or laminar flow are working or not properly, you have to send air cultures. This is the actual reason behind it.
Thank you, sir. To conclude the entire session, take-home message from our panelists and any input if we have from our respected invitees. Take-home message after which we'll conclude the entire session and proceed for the vote of thanks and dinner. Take-home message.
The best take-home message that I have taken and I will be reinforced as physicians, we'll make a two-way communication with our pathologists, bacteriologists and radiologists to make our practice better and a better diagnosis and help the patients more.
I also want to thank you, Dr. Saab, you being a neurosurgeon. Shame on us physicians that we did not take the initiative, and I am impressed. And this is a very important topic, very important for all of us. Not just for you, for all of us. It is only for our betterment. Thanks to you.
And at the same time, my sincere and utmost thanks to Dr. Dhanvantari Shukla sir. Actually, I think in my whole clinical journey since last 8-9 years, this is the first time on a stage I am talking about antimicrobial resistance. Although we have already read through books and journals that it is going to be the next pandemic worldwide, and To your surprise, the last year data was 2.5 lakhs deaths were reported only because of antimicrobial resistance in India. In India, it is not worldwide. So just imagine the situation which we are going to face. It is not even 100 years has gone since the penicillin was discovered, and we are in a menace of what antibiotics we are going to use further. So please, my utmost and sincere request to each one of the clinician, please use the antibiotic judiciously. If we can all come to one single forum to how to stop the over-counter sale of antimicrobials at the pharmacy level, so we can also do that. This is one of the things which is a challenge for all of us, but we should really think that this is a high time and no other big moment is going to come. This is the time. Thank you.
Take this advantage to thank Dr. Shukla. He has come up with this topic. We have come to our lab to discuss this topic, and actually it was such a good initiative taken by him, because this is a daily problem that we are facing, and we get a lot of calls in our lab. We are working in our lab according to the international guidelines, and many a times we get this kind of questions that we have addressed just now, that there are so many antibiotics in the reports of the other labs, while you are giving only few antibiotics in your lab, so maybe you are not working as for the good report that is needed. But here again, as Dr. Piyush and Monica ma'am have highlighted very clearly, that we have to work according to the guidelines. We have to identify the bacteria, the bug which is there, and accordingly the antibiotics are chosen, and according to those antibiotics which are relevant, only those are put up in the test or in the culture sensitivity report. And therefore I would request all of you that as you fight the infections and these difficult problems every day, please take care that you are getting yourself reported from a lab which is following the international guidelines, or is at least having a microbiologist to back up and report the cultures and other infections for you. Thank you so much.
Thank you, ma'am. Now I will request Dr. S.A. sir to please come up on the stage and honor all our panelists with a small token of appreciation. I would like to thank all the panelists, all the invitees, the Diva Charitable Trust, the Newborn Parents, the hotel, the media persons, and now one by one we'll just have this memento presentation, after which we'll proceed for dinner. I am really impressed with your presence, and I hope we'll keep gracing such events with your presence. Thank you very much.